We've officially started.
All right. So my name's Andrew. I'm with Carol this month. I'm a pharmacy student from the University of Findlay, and I'll actually be here till March. I just won't be with Carol the whole time. I'm just here till the end of the month with her. So if you guys do have any questions with this later on, I'll probably be in the hospital somewhere, so you'll be able to get in touch with me. So today we're just going to be going over with anthracyclines as a drug class, just things to look out for with them, proper monitoring parameters, and just really the main things to touch on with these drugs. So in this class we see doxorubicin, daunorubicin, epirubicin, idarubicin, and then valrubicin can be used for bladder cancers, but it's not seen as often. And they were actually discovered from a bacterial species called Streptomyces in the 50s, and then started to be used for leukemias and lymphomas in the 60s. So they're pretty old drugs, and they work through inhibiting topoisomerase II in the DNA replication process. So that creates a double-stranded nick in the DNA. The anthracycline can then slide in and kind of stabilize that structure, so then this nick that's created stays broken. So then this accumulation of breaks in the DNA then results in decreased integrity and then cell death. And it's going to target fast or rapidly growing cells, so that's how it treats cancer. Its uses are pretty widespread, so we're going to see it in leukemias and lymphomas, breast cancers, pretty wide range of cancers for treatment. And the main side effects that we're going to see with these medications is cardiotoxicity, and I'll talk a lot more about that later because we actually have lifetime dose limits on these medications. They're also vesicants, and like many other cancer drugs, they can cause bone marrow suppression. And a little thing to note about these are secondary malignancies, so you can actually see AML like years down the road after you've been treated with an anthracycline. It's just one of those things to watch out for if you have a patient come back in and they have maybe signs of AML. It could be linked to past anthracycline usage. So dosing these medications, like a lot of other chemotherapies, it's based on body surface area, and it's going to vary based on the number of cycles, type of treatment you're doing, and just the regimen you're using. Dosage adjustments is all going to be based on liver function, so mainly with the bilirubin, and it does vary between agents. So I'll run through doxorubicin, but just keep in mind that so if you're using daunorubicin or epirubicin, it is going to keep the same parameters for the bilirubin levels, but it's not going to be the same dose changing parameters. So with doxorubicin, where you have a bilirubin of 1.2 to 3, you administer 50% of the dose, whereas with daunorubicin, that same range, you can still get 3/4 of the dose. So it's just something to keep in mind. You're not always just going to half the dose if you have an increased bilirubin. And an important thing to note out with these medications is there is a lifetime allowance for dosing in the anthracyclines due to that cardiotoxicity. So with doxorubicin, throughout the patient's life, they can receive 300 to a max of 500 milligrams per meter squared of dosing, and they start that real close monitoring at 300 milligrams per meter squared because around 1 to 2 patients will experience cardiotoxicity or issues with their heart at that level, but then by 500 you see it in 6 to 20% of patients. So it happens in a pretty large percentage of the population once you get up there in dose. Dosage limits do vary between the medications just due to potency. So if a patient has received doxorubicin in the past and now they're going to be getting epirubicin or daunorubicin, my suggestion would just be do a proportion, see where they're at in their lifetime dose, comparative, and see what they have left to give for that secondary agent, just in case they're getting close to their max. So the next thing to watch out for with anthracyclines is their emetic potential. So they are pretty heavy in inducing nausea and vomiting, especially doxorubicin at a high dose over 60 mg per meter squared. That has a high potential, which means over 90% of patients are going to have an episode of nausea or vomiting. The other medication that would be dose dependent is epirubicin, over 90 mg per meter squared. You can see a highly emetogenic potential with that agent. So in treatment of emetic therapy, one, we got to make sure that we're properly covering them before we give the chemotherapy. So we want to make sure that we're giving these agents around 30 minutes before their treatment dose, just to make sure that they're properly covered before we're giving the therapy. We don't want to be trying to play catch up with these patients. So on day 1, we're going to give an NK1 antagonist, so that'd be like aprepitant, fosaprepitant, 5-HT3, so ondansetron, maybe palonositron, and then olanzapine and dexamethasone. And then for highly emetogenic potential anthracyclines, we're going to treat for 3 days after, just to cover them for refractory nausea and vomiting with olanzapine and dexamethasone. For moderately emetogenic agents in this class, we're going to see that 5-HT3 with dexamethasone, and you can add a third agent on, like olanzapine or an NK1. And then we're going to treat for 2 days after that initial dose to cover them for moderately emetogenic. And you can do that with your dexamethasone or some Zofran. For low emetic potential, we're just going to give a monotherapy, usually with the steroid or prochlorperazine. Metoclopramide is an option in here, but at this high dose, we kind of worry about other side effects with that medication. So mainly I would see dexamethasone or prochlorperazine in that case. And we're still giving it 30 minutes prior to therapy. It's just more monotherapy. With the minimally emetic potential, we're really just doing PRN medications, so we don't need prophylaxis with those agents. Okay, so getting into the bulk of administration and management during infusions. So there are some tests that we need to do prior to administering anthracyclines. The first of which is a pregnancy test before each round, and that is for patients in age 8 to 55, but that is just an age range that Premier has made. So if you work for Kettering or another place in the area, you could see a variation in the age range that they require for pregnancy tests. It really just varies. But you have to make sure that you counsel patients to use adequate contraception 3 to 6 months after their last dose of their anthracycline as well, just to cover for the potential teratogenicity. You also need to monitor cardiac function, looking at the ejection fraction, getting a baseline, and then every 3 months during treatment and annually after. You can do that through the echo or a MUGA. And just monitoring for a decrease in that ejection fraction over time. So if you see something decrease, your ejection fraction decreasing below 45% or a 15% decrease from baseline, we really want to discontinue therapy for now, reassess the patient, and make sure that they're not having cardiotoxic symptoms that we'll go over in a minute, and really proceeding with caution because we don't want to increase the risk of cardiotoxicities. Also want to do your CBC with differential, get your renal function test, liver function test, and make sure they're properly hydrated on these medications. Infusion management. So the rates of infusion vary between agents and between the regimens. But in general, because it's a vesicant, we want to make sure we're giving it via central line and not administering IM or SC. And we can give it in D5 or normal saline. I'll run through doxorubicin real quick with that. So you can infuse it over 3 to 10 minutes or through a central line extended infusion over 24 hours. It really just varies, but you need to make sure to protect it from light until you're done with the infusion. So the next thing is going to be extravasation. So since these drugs are vesicants, we need to keep an eye out for that. And the signs, I'm sure you guys have seen it in patients, is the just extreme pain in that area, burning sensation around the infusion site, redness, maybe streaking of the veins, and in later stages, blistering, ulceration, and even skin necrosis. So management of that, we're going to stop the infusion as soon as we notice those symptoms, but we're not going to remove the line immediately just because we want to aspirate that fluid back out as much as we can safely. And if we have an antidote available, which we might not have it readily available here, but we want to make sure that we still have that line in just in case we need to give it. But after you've aspirated the fluid, and if there is not an antidote available, you can go ahead and remove the needle or the line, and then elevate and use, for anthracyclines, it suggests cold compresses, so a cold, dry compress for 20 minutes 4 times a day. And we're also going to be monitoring for increases in size and just the skin condition, so maybe using a surgical pen and kind of drawing a circle around the area, seeing if it is progressing. And then there are antidotes available, so you can use the dexrazoxane at 1,000 mg per meter squared over 1 to 2 hours on days 1 and 2, and then 500 mg per meter squared on day 3, if that's available for you guys, and that would be Totect. We'll get into a different brand name for that antidote used for a different purpose here in a minute. The other option is dimethyl sulfoxide, where you can apply it topically to twice the size of the area that's affected, but it has to be done within like 10 minutes of the extravasation occurring.
Do we carry those? Do we have those?
We'll
talk about it later.
Yeah,
Oh, okay.
I don't know if they're readily available to use.
Okay.
So, looking at cardiotoxicity as a whole, we'll jump into the mechanism first. Anthracyclines create free radicals when they're metabolized, and those free radicals and superoxides, like hydroxide ions, peroxide ions, end up damaging cardiomyocytes, so the muscle cells of the heart, and that's categorized as a type 1 toxicity because it causes cell death. And over time, as that builds up, we can have an increased risk of cardiotoxicities, such as like heart failure, arrhythmias, stuff like that. So some symptoms that we'll see is that decreased ejection fraction, and then signs of like heart failure, so fatigue, shortness of breath, peripheral edema, arrhythmias, stuff like that. So risk factors we're going to see is extremes of age, actually the female gender as well. And then pre-existing conditions that can affect the heart, so hypertension, high cholesterol, diabetes, things along that nature. And looking at when to intervene with a patient with cardiotoxicity, so trying to kind of pick out when we want to stop therapy. So it's normally delayed. We're not going to see this until like months to years after therapy. It might just present later on for them. But we just need to consider that risk as they're getting higher in the dose for their lifetime allowances throughout their life. So we just need to consider the basically benefits versus the risk of further treatment. So if we're treating the cancer, we're seeing improvements in the cancer, is it smart to stop it now because they're having cardiotoxicity, or try and continue treating the cancer just in a case of how long do they have left to live, or what is their prognosis? Are we going to see them in here later because we just nuked their heart, or are we going to try and help them with their cancer? So it's just kind of something to consider, where it might be smarter just to discontinue the therapy just to save their heart. Another option is the dexrazoxane, which is the antidote for the extravasation. It can be used in a 10-to-1 ratio with doxorubicin when you're getting to those higher limits of the lifetime expectancy, so around like 300 milligrams per meter squared and above. And you'd use it in a 10-to-1 ratio. So on to our clinical pearls. So patients that have, let's say, breast cancer, and they get chest radiation for the tumors in their breast. If that's around the heart, it could end up leading to damage in that tissue area, maybe leaving them more susceptible to cardiotoxicities that are associated with anthracyclines when they're being treated with them. So we just need to assess and make sure we're not leaving them at a higher risk when we're treating these patients if they've received radiation in the past, and just monitor them a little closer. So if we were to normally get that ejection fraction every 3 months during treatment, maybe do it every month or even before every treatment phase, just to make sure that they're not progressing. Another thing to point out is spills. So it's a highly emetogenic agent. It causes diarrhea. We could just end up having a leaky bag, never know. But they are hazardous drugs. It's NIOSH Group 1 medication, so we're going to recommend cleaning the spills and the bodily fluids with double gloving, protective gown, eye and face protection and respiratory protection if there's an aspiration risk. And then excretory cleanup precautions. So these medications might just be used for like a single dose, but then they can stay in the patient for extended periods of time. So we got to keep that in mind if they do have like diarrhea later on or side effects bringing them back into the hospital after a few days post their infusion. So if you have somebody coming in who received doxorubicin 4 days ago and they have diarrhea, cleaning up that diarrhea needs to be taken with precaution because it can remain in the feces for 7 days in the case of doxorubicin. That does vary between agents. Like epirubicin is only really in the urine for 3 days, not in the feces. And then idarubicin is only in the feces for 2 days. So it's just something to keep an eye out for. It depends on how long ago they received that treatment. But looking into side effects now, just a couple clinical pearls there that's different from other agents is we can see some kind of odd discoloration in tears, urine, and sweat. So it's kind of like an orange to bright red tinge. So it might be kind of alarming to the patient. So just you want to let them know that it's a normal side effect of the medication, and it can actually stain contacts if they wear contacts. So it's just something to keep an eye out for. And, and it can be alarming to the patient if, I mean, they have contacts that are red now. They don't. It's just kind of something to make sure they're aware of it before they receive the medication. You can also see changes in nail appearance, so they kind of get like rounded, it seems, and then mouth sores and irritation. Okay, so implications to therapy for nursing. All of this stuff is very pertinent to you guys. You guys are the ones administering the medications. I mean, pharmacists might be the last check before it comes up to you guys, but ultimately you're the last check before it goes into a patient. So everybody makes mistakes. Maybe the pharmacist missed something, and if you guys can catch it, that's awesome. So just going on with that, just making sure that they're using the right type of line and making sure that the line is placed correctly so we're not at risk for that extravasation or anything like that. And making sure that it's in the proper solution, so at D5 or if it's in normal saline. And checking that solution right before you place it, making sure there's no settling or precipitants in it. Obviously that's a precaution we definitely want to take with pretty much any medication, but it's just something to think about. And then just raising questions. So have they had their ejection fraction checked recently? Are they getting close to that lifetime dose limit? Anything along those lines, or if they don't have any orders right now for emetic therapy, so if they're on a high dose doxorubicin, did they receive their like 5-HT3 NK1 steroid before, like that 30 minutes before the dose? We just got to make sure that they're getting it so they're properly covered. And just making sure that they can clear the medication after it's given, so assessing for that renal and hepatic function. And then there's knowing when intervention is needed, so stepping in when you see those signs of extravasation, looking for signs of an allergic reaction maybe to the medication, or if you're seeing signs of cardiac dysfunction while they're in for treatment, like the reduced ejection fraction and VFib, AFib, shortness of breath, peripheral edema. And then looking out for tumor lysis syndrome in our patients with a higher tumor burden. So looking at renal function tests, looking at uric acid levels, making sure that they receive proper hydration while they've been receiving treatment. And then, like I said at the beginning, I'm here for the month. I'll be here until March to reach out to me, but since you guys have listened to this presentation and just teaching others, if you have a nurse floating down here for the day or for the night, make sure if they're administering these medications that they're aware of these precautions, you know, telling them that all these risks associated with the cardiotoxicities and with the infusion-related issues with the vesicant nature of the medication, and making sure that they're on the same page with you guys, basically. And I'm sure you guys do that anyway. It's just one of those things.
I have a really dumb question.
Okay.
So I noticed there's a lot of talk about like liver and bilirubin, and is that just because of that's where that's mainly
It's
like broken
metabolized,
down
yeah.
and, yeah, okay.
It's metabolized there.
I figured, but I didn't wanna not ask.
Yeah. No, that's perfectly okay. That's a solid question. So now, open up the floor. What questions do you guys have on anthracyclines?
I was just having a question about the,
Go for it.
so we don't carry any of the antidotes in the hospital, so if we had one, what would we do? Would we be able to get the medication from somewhere?
I'll step in and answer
Okay.
because he won't know the answer to this. So Totex that they use for extravasation from anthracyclines has been back ordered for about 5 years. We haven't actually been able to physically get it.
Oh, wow.
wow.
So, and DMSO is very hard to obtain, and knock on wood, we have not had an extravasation that has occurred here that we've needed it.
Okay,
I hope we never have to cross that bridge.
yeah.
That being said, we did have a patient I told him about 3 or 4 years ago, I think at least, who was a male breast cancer patient, extravasation of doxorubicin with his last dose into his arm.
Oh, wow.
And by the time we had seen him, it's a plastic surgery issue at that point
Ooh.
because it's debridement of dead tissue with
Wow.
wound healing. And he recovered nicely, although this was done in an outside facility, so I don't know what they gave him.
Wow.
Even the Zinacard, which is the same drug, just marketed differently for cardiac toxicity or to ease the cardiac toxicity or prevent it, is back ordered too. We've not been able to get it.
Wow.
Really does.
Wow.
Yeah.
If we did have
Had it
something
years
like
ago.
that, it wouldn't be something we would have, I mean, I imagine it's extremely expensive or
It's-
something
yeah,
if you
it's
can't
not
get your
cheap.
hands on it, so we wouldn't have it up here anyway, correct?
No.
I mean, what's the probability of getting something in 10 minutes from the pharmacy if,
Right.
Next to impossible.
Yeah.
Because you know how we work.
well, I mean,
Right.
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 But it would, if the extravasation is bad enough, you will have contacted the physician to have him come look at it. And he may look at it and say, plastics needs to come look at the person. We hope we never get to that point. That's why we're so diligent about peripheral lines need to be really fresh, good lines. A lot of our stuff is put through central lines, and while yes, the central line can still extravasate, the risk of it is so much less than a peripheral line. So,
Right.
prevention is always the key to preventing these things from happening, but it's good to know that there's something there.
What else you guys got?
So my only other question is, do you have this electronically?
Send it to
I
you.
do, yeah.
Thank you.
And it's
I will put that in this way as well then, with this, and
You
send
hit
that to
all-
everybody.
You hit all the major points.
Yeah.
Thank you.
Thank you so much.
Yeah, no problem.